the SHAPE 1. It is also a chapter in the SHAPE book, but we want to see if anything new has come since then, and Sanjay will pick up whatever Erling left. Go ahead, Erling.
Thank you, Sanjay, that you will pick up what I'm missing here, because I'm not going to give a review on this area, just going to highlight some recent observations. I will start with this paper published in Lancet in 1994 by Wald and Law. It's an observational study where they did a health screening on a lot of men and followed them for nearly 10 years. Then they did a nested case control study. The cases was 229 men that died of ischemic heart disease. And then they saw what was the risk factor they measured at baseline. And they found here is the frequency distribution of serum cholesterol for the men that died of ischemic heart disease and those who did not die of ischemic heart disease. And you can see that serum cholesterol was a very poor discriminator between cases and non-cases. In fact, you could nearly as well flip the coin. So they concluded that it is not advisable to screen for ischemic heart disease by measuring any combination of risk factors. Recently, we repeated this study in Copenhagen, did a nested case control study. It was published a few months ago in Clinical Chemistry. And we measured and would try to find risk factors for near-term myocardial infarction in apparently healthy men and women. Predictors for near-term myocardial infarction in a nested case control study where we measured established risk factors and 17 putative biomarkers. I will only focus on the established risk factor now. 252 cases, 499 controls, and here we have the frequency distribution of total cholesterol cases in red and controls in black, and we can see there is huge overlap in the distribution. In fact, there is no predictive power in total cholesterol. Systolic blood pressure, the same, no predictive power. And cholesterol, blood pressure, and smoking, AIDS, and that was adjusted for AIDS and sex. So if you adjust for AIDS and sex, there's in fact no predictive power left for cholesterol, blood pressure, and smoking together. So we could confirm that the traditional risk factors are poor predictors for ischemic heart disease. Wald and Law concluded later in this paper in British Medical Journal that if we can't find them, let's treat them all. Everyone over a specific age, for example 55, without requiring risk factors to be measured. It was the poorly pill principle they introduced here in the British Medical Journal. And they said that a pill could prevent 80% of heart attack, a poorly pill containing a statin, 3 antihypertensive agents at half doses, folic acid to lower homocysteine, and aspirin. And they combined these principles, 6 in 1 pill, fixed doses, and off-label use in primary prevention. They updated their view recently in heart. Here we have it, Wald on the top, it's the father, and now he has his son, Davis Wald, has joined him. And they say here, until recently, statins have been prescribed only if serum cholesterol is raised. Blood pressure lowering drugs are given only if a diagnosis of hypertension has been made. This is inappropriate and leads to many people not receiving preventive treatment who could benefit from receiving such treatment. And they say now that maybe more than one poorly pill will be needed because many don't want to give aspirin today in primary prevention, and folic acid to lower homocysteine is not really the case. They also said there is no specific there is no scientific doubt that a polypill with at least 4 components, 3 blood pressure lowering agent and a statin, could safely prevent most cardiovascular disease events. The target population is healthy individual, and they say it would be perverse if they had to become patient and see a doctor before obtaining the treatment. So, they have a polypill program, polypill preventive program at the Wolfson Institute of Preventive Medicine in London. Just call David Ward, and he will mail you a polypill after a few questions. And if you have other questions, there is a helpline. So all is via mail and via the phone. They are treated with these 5 agents: simvastatin, a diuretic, an ACE inhibitor, a calcium blocker, and folic acid. It would be ideal to have all these components in a single pill, but such a pill is not available today. It's an off-label use of many of these drugs because heart attack and stroke are common in people over age 55. About 1 in 2 people will be affected in their lifetime. And most events occur in people with near average level of risk factor, such as blood pressure or cholesterol. That is, they have no hypertension and they have no hypercholesterolemia. Recently, they offered the program to one of Britain's largest company, and now they can be prescribed a polypill if they want it. Okay, it is not a polypill, but it is multi-drug what they are offering in the Institute of London, because they don't have the pill they would like to give. They hope they will have it in the future. What's his name? Yusuf. Yusuf has started a polypill program called the Indian Polycaps Study Tips, where they try to come these 5 active ingredients in a single pill, and they have studied how it affects the risk factor level. There is no event outcome from this study yet. So it's a real polypill program, but no event. But maybe it's in fact outdated. Let's look at the polypill paper again. Today, I think no one will consider to give folic acid. If we are talking about primary prevention, many would not like to give a statin today. Will not like to give aspirin today. So we can eliminate folic acid and aspirin in primary prevention. Then we have a statin. It is generic and cheap today. And 3 antihypertensive agents. In fact, you have them already today in 1 tablet. So you don't need to produce a new tablet. You have a tablet. Its name is X-Forge, and it contains amlodipine, valsartan, and a diuretic. Amlodipine and calcium channel blocker, that is a very popular agent in hypertension. Valsartan, that is an angiotensin receptor blocker. In fact, these 2 drugs are the 2 drugs that are most frequently used today to treat hypertension. It already exists. Amlodipine is generic, the diuretic is generic, valsartan will be generic in 2 years. So maybe you will soon have a pill containing 3 antihypertensive agents in a single pill. This paper from Law and Wall again, it was published in British Medical Journal last year on the use of blood pressure lowering drugs. And they conclude here from this meta-analysis, guidelines on the use of blood pressure lowering drugs can be simplified so that drugs are offered to people with all level of blood pressure. All level of blood pressure. Not only hypertension. Our results indicate the importance of lowering blood pressure in everyone over a certain age. It is patients not with a high level of risk factor, but with a high level of risk. Rather than measuring blood pressure in everyone and treating it in some. In fact, that principle is now being tested to some extent in the HOPE-3 trial by USEF. In the HOPE-3 trial, it is a primary prevention trial, and we know that atherosclerotic cardiovascular event to a large extent is preventable, also shown by USEF in the INTERPART study. And he say here, however, as we have said many times, most heart attack and stroke occur in people with average normal cholesterol and blood pressure level. They are recruiting 11,000 participants without a clear indication or contraindication to a statin, rosuvastatin. Hello.
Yeah. I think it's time.
Okay, that's fine.
Can we get another one?
Here. Thank you. Rosuvastatin and two drugs to lower the blood pressure, candesartan, it's an angiotensin receptor blocker and a diuretic. And it is off-label use of these three agents in two pills. So it's a kind of polypill principle. So in fact now we have an effective way of preventing the first heart attack. What we talked about earlier today, this paradox that mortality is declining, but the prevalence of costant cardiovascular disease is increasing despite great advances in technology and treatment, because it's very expensive to treat manifest atherosclerotic cardiovascular disease. Valentin Fuster is running also a real polypill trial in secondary prevention. But the polypill contains aspirin, simvastatin and ramipril, and it's drugs that already are indicated to treat patients after a myocardial infarction. So there is no problem in indication here. It is not off-label use of these drugs. It is on FDA-approved indication. The only thing here, you have these active ingredients in a single pill, so you may improve compliance. If we go back to Charles' paper published in JACC just a few weeks ago, and to the editorial by Lau, I will focus on the last sentences here in this editorial, where he also mentioned widespread use of statin or polypills. He compared it with a global risk factor assessment to find those with high risk and imaging, and he also said, well, we may also use a polypill to prevent heart attack. And he said here, our next step is to have the humility to admit that we do not know which approach or combination of approaches is best, but that in the public interest we will join forces to design and implement the definitive large-scale randomized trial that our patients and the public should rightly demand. So in fact, the polypill principle is still alive, and even Michael Lauer thinks it's worth to test in a clinical trial. So just to repeat, in 2003, we had this paper in British Medical Journal, 6-in-1 pill, fixed doses and off-label use. And today we in fact have 4 of the most active ingredients in 2 pills. So we are approaching the single polypill. So we can reduce 4 active ingredients to 2 pills. So I think there has been some progress in recent years, and all these drugs and these pills will in a few years be available as generic drugs. Thank you.
Great.
just so everybody can pace their blood glucose level, we don't have any more presentations. There will be 2-3 minutes talk by Sanjay and the rest of the comments, and we're going to conclude today's meeting. Please go ahead.
Well, I think Erling has already articulated some of the core issues relating to polypill. I mean, he's gone over some of the trials that I've looked at. I just want to make one comment. I think we have to make a critical distinction between unconditional treatment strategy versus polypill, because unconditional treatment strategy basically says that you just treat all, as opposed to what the SHAPE and other guidelines are saying, test it all, but treat only a few. And that unconditional treatment could either be based on monotherapy, statin alone, or it could be based on a combination therapy, statins plus antihypertensive. Recent evidence has emerged, well, it's not really recent evidence, but at least we are beginning to understand better that perhaps aspirin may not be a panacea that we thought it would be for primary prevention. None of it is recent. In fact, of the 7 or 8 primary prevention trials with aspirin, there's only one study that ever met its primary endpoint. The physician's health study that is often quoted was stopped for futility. And it demonstrated a 50% reduction in MI, which was not associated with any impact on mortality. And so there's never been any single primary prevention study, except for the thrombosis prevention program, that reduced myocardial infarction. But if you include silent myocardial infarctions, then that statistical significance is lost. But the reason why we were fooled by when the studies were pooled together in a meta-analytic form. That's the reason why I have very little faith in meta-analyses, when you pool data together and you can get a statistically significant p-value. I think the TIPS study that Salim Yusuf conducted is the first critical step towards pharmacologically targeting the global cardiovascular disease burden. But it may only have implications for countries where public health policy drives healthcare. I'm not quite sure whether that might have implications for our environment, where individualized patient care seems to be the dominant practice pattern, where physicians believe in titrating therapy to some degree and frequent visits. From a regulatory perspective, there are some issues with regards to whether this polypill concept should apply to primary prevention versus secondary prevention. Some would argue that the evidence is already there for secondary prevention, so why should we even bother? But we haven't tested the safety. While we know about the efficacy, we haven't tested the safety issues for secondary prevention. For primary prevention, both safety and efficacy need to be evaluated. Already talked about different pill combinations. You know, do you use sub-maximal doses? Do you use maximal doses that have been of proven benefit in trials? Salim Yusuf is following his TIPS study by TIPS 2, where he compares the low dose that was utilized in the TIPS study versus the double dose. Because the simvastatin that he used in TIPS 1 was only 20 milligrams, and only 40 milligrams of simvastatin has been proved to be of benefit. And so those are the type of studies that are being conducted. In addition to the studies that was mentioned by Erling, there's another program started by the investigators in Sydney, Australia. It's called the SPACE program. And they've started this red heart pill studies. The first one was launched in UK, Ireland, and Netherlands, called the Umpire study. It's in the high-risk patients. There's another one called GAP in Australia, another one Impact in New Zealand. The only WHO-sanctioned study is initiated in Sri Lanka. And Wellcome Trust is initiating another 5,000 patient study in India using Reddy Laboratories polypill. I think the only advantage that I see of polypill is compliance. If you can enhance compliance, then it makes a lot of sense to use polypill. In the TIP study, the compliance rate was about 82%. In other words, 18% were not compliant. And you can look at it and say that that's not a great compliance rate. But remember, TIPS was conducted in healthy people, not patients. And it's very difficult to convince healthy people to continue to be adherent to pharmacotherapy. So I really don't have anything much to add other than there are about at least half a dozen studies that are examining the role of polypill. If I were to hazard a guess, I think it's more likely to be successful in the third world or the developing countries rather than in the developed world.
Yeah, and I'll pick right from where you left it. That was the conclusion in our previous meetings, that if you don't have any way to justify testing because they're not available, you don't have chronic calcium, you don't have carotid scan, and you want to do something for that population. And that's where I think Salim Yusuf's motivation was. He's originally perhaps from India, understands economy and the population, a huge population. Same thing in China. Maybe those countries can adopt polypill, but in the U.S. a major issue is regulatory issues. That there's no way you can go to the FDA and say, I'm going to give everybody a combination of these pills. And so Michael Jameson and I wrote a paper, which is also a chapter in our book, and we list almost 20 some different various barriers to adoption of polypill in the U.S. and European countries, mostly U.S., and it starts from regulatory in different aspects of regulatory. And then you come to compliance. We actually think that compliance is gearing towards screening, because if you know that you have a bunch of plaques in your heart, in your coronary, you're more motivated to take that pill versus if you don't know and you can just wish that you, or dream that you're not part of those high risk. And so I think compliance is, yes, instead of taking 6 pills, taking 1 pill is easier, but compliance at a societal level, population level, is much higher, expected to be higher when you have a test that puts you in high risk level or define plaque versus you're totally blind your risk, individual risk level. Yeah. So these were several things, and it goes all the way down to really, who's going to promote the test, a pill, and there will be a ton of these companies, counterfeiting like Viagra, going across the border. There will be very poor oversight in, translation of that to the outcome is that people thinking they're taking these vitamin B or vitamin, multivitamin, and we know they are not translated to health. They're at best placebo. Go ahead.
Well, I think it's important to understand that the concept of polypill is not a new one. It's already been tested and established, very effective in TB, tuberculosis, and HIV.
Well, that's different.
The concept works. I mean, the argument that you're making that you cannot ensure the quality of the ingredients
and
effectiveness.
In HIV, you have a test, you measure it, you know it. You don't come and treat me for HIV.
The concept of polypill has been established and well characterized and to be very effective in third world countries, especially from pharmaceutical companies, where India has taken the leadership and provided these combo pills to countries in Africa where HIV is a huge problem. So I think if we can do these kind of studies, like there are about half a dozen studies, to see that in an environment which is permissive to this concept, if we can prove it there, then I think it will be a major step forward.
Yeah. I think we're going back to
so it'd be very interesting to look at that 12,000 person UK company to see how many people actually stay on therapy. Because in a randomized trial, if 82% stay on therapy, then in a non-trial environment, that number could be, who knows, 20%, right? I mean, there's no perception of need if you're a healthy asymptomatic person. And we can't make an asymptomatic person feel better. So if they don't perceive the need to take the medicine, so I don't think we can look at compliance in a randomized trial and exactly extrapolate it to if we recommended it to all. So I think the best trial that's ongoing now to see if this is realistic or not is that energy company that in the UK is offering it to its people. One, how many are going to say yes to it, right? Because it's going to be, they can't force the employees to take it. And two, at 1 year or 2 years, how many are still on therapy? And if the answer is 20%, then this is a non-starter. If the answer is 80%, then obviously this has some traction. So I think we need to see the real-world experience of poly pills. I agree with Sanjay. The concept is good. The more pills you put together, the more pills you put together, the better the compliance gets, but that's only with a perception of need. I have a positive HIV test where I have tuberculosis, my perception of need is much higher to stay on therapy than if I feel great and somebody says, oh, everybody over the age of 55 should take 4 medicines. I don't think that's going to fly as well in the US, but we'll have to see. All excellent points.
I'd like to ask a question about the ethics of this poly pill. Really? No, I'm serious.
Ethics?
Ethics of a poly pill.
Meaning?
If I'm a healthy person, why should I take any pills? I have a problem with that. I really do.
Because 1 out of 2 in UK or 1 out of 3 here are going to end up having a cardiovascular event. We have a tool or combination of pills, according to Wall or other studies, that can reduce that event rate by 60, 70, 80%.
Would you get vaccinated for a disease?
I have, yeah.
Why is it different?
I see it differently. I don't know why, but I do.
Is
I
daily
don't-
intake of a pill with side effects versus a one-time shot? I mean, a vaccine
Yeah, so
is,
if you're afraid of side effects,
No, I'm not afraid of side effects. I'm just sort of raising the ethical question of giving everybody
If
a...
you read Wall's paper, it basically is there is a huge amount of burden of disease,
Right.
and you just take it out, that's why we're...
That's-
The problem is side effects, there are side effects.
Right.
So, let's try to give you is there any comments here? Is there any other comments in the room that we need to hear about polypill? Because as I said, the conclusion last time was that polypill is not ready to be recommended. The SHAPE task force would not recommend unconditional therapy, and it was not ready. I know we lost George Diamond because of that. He was very much in favor of polypill. But our view for... Go ahead, Sanjay.
I think it is fair, a model, which I'm sure some of you may know of, it's called the Archimedes model that was developed by David Eddy, and that's being promoted by General Electric. It's a mathematical model, and in that model we compared the SHAPE strategy, the CRB strategy, and the unconditional treatment. Now the cost that was factored in there in that model for CAC screening was, I think, about $175 or $200.
You put $400.
No, that wasn't our paper. I'm talking about this Archimedes paper that we presented at the ACC. It was, I think, $200. And we looked at all the sensitivity analysis, looking at compliance with unconditional therapy of 100%, 50%, 30%. And even at 30% compliance with statin and aspirin therapy, in that model, unconditional treatment won. The primary endpoint here was cost effectiveness, followed by the SHAPE strategy, and CRP came last. There were some issues about CRP sampling, whether it was accurate or not. So if you believe whether this model is a good predictor, then unconditional therapy won in that. Now, you can argue that if the coronary calcium screening costs $100 tomorrow, how will it compete? The numbers, if I recall, were that for every event saved, it was $9,000 for unconditional therapy, and it was $15,000 or $16,000 for coronary calcium screening, based on a $200 cost. If it's $100, perhaps it will be comparable.
Yeah.
But this is just purely based on a model.
Yeah, that model is that throw it at any metal, it becomes gold, and that's in our community. Erwin, go ahead.
May I say,
Sure.
hello, may I say a few words here? Unconditional therapy, that means you will treat all.
Everybody.
Yeah.
No,
May-
the specific risk cohort.
Yes, but all in that specific.
Everybody in that group.
For example, everybody about 55 years. That's right. Then I say also in response to what was said up there, why treat all? If you with a simple and easy and safe test can say maybe 1/3 don't need the treatment, do a calcium score. And you will see 1/3 have a calcium score of 0 and they don't need the treatment. Maybe it's not cost effective, but I think it's good medicine to use the money to find the people who don't need treatment. So it's the opposite of shape where we try to find the high risk. Maybe here we should find those with low risk and treat the rest.
Perfectly reasonable and defensible hypothesis. Now, let's validate it.
Alright. Okay, so we're going to arrive at the end of our Saturday, and tomorrow we'll be starting just like today with a very fiery 2 hours, but that will end up reaching consensus based on all the points that we've collected. And then after that, we're going to talk about now real practical matters. Who is going to do it? Where is the reimbursement? And what are the barriers to that? And hopefully before noon, we'll finish the consensus on that level as well. Today, we have a private cruise scheduled for us. I think we have about an hour. Monique, is it an hour? Jeff? Okay, well, I'm going to hand it to Jeff. Go ahead.
For anyone who's going to attend the dinner cruise this evening, this was handed to me. We'll be boarding the dinner cruise. Boarding begins at 7:45 p.m. You're to walk to the dock E, as in Edward, 800, which is along the boardwalk, right outside this meeting room by the pool. Okay, E800, right out here on the boardwalk by the pool. 7:45 begins boarding. I know it's scheduled to depart at 8 o'clock, so kind of a small boarding window.
Okay, great. So it's about an hour and 45 minutes from now. The dress code is formal. The dress code is formal. Business casual. Business casual with your shape hat. Okay. So please help yourself, stay around and enjoy your time here. We will provide the presentation of this meeting to everybody. So make sure you get that tomorrow before you leave. And Monique and Jeff, we need you to make sure that they're all on one slide. Yeah. Thanks everyone. Have a restful rest of the day. Today, I also got an email from our chairman, PK, Dr. Shah, who was dragged to an Indian wedding late last night and had to stay there till 2 o'clock, so he's running late. Other than that, everything seems to be in good shape, beautiful breakfast place, and we're all energized to get started. Our first presenter will be Jim Ehrlich. Jim has been in the field of imaging for as long as I know.
It only lasts 24,
as
I
long
guess.
as I have been aware of this field. But he has been fighting his battle on the ground level. And working with practicing physicians, I don't know how many thousands of millions of miles you put Jim, but that experience of seeing practicing physicians was very essential to ask Jim to put together this presentation. because he sees the reality. It's one thing sitting in Texas Heart Institute or Johns Hopkins or Cedars-Sinai, seeing patients and managing prevention clinic. It's another thing of going out on the street, building diagnostic clinics and preventive centers, and dealing with doctors. He also worked both in the industry and academia, and that was helpful too. So with that, Jim, please take us.
Well, thank you, Mort. Of all the introductions I've had, and there have been distressingly few, this one, what can I say, is certainly the most recent. So thank you. Anyway, I want to mention that George Rogers, who was originally signed also to share with me this topic, was very helpful. And so some of the slides are for George, and George might interact here. He's going to give a talk later specifically on obesity and metabolic syndrome. After introducing centers in various cities since '95, we've had difficulties, all of which are much better than they've been in the past. But I think it applies to our SHAPE group. So why don't primary care physicians, why don't they screen for coronary disease? And the basic reasons that I'll go into in more detail is ignorance and uncertainty, and fear. Reactive orientation is supported, so there's a certain role confusion. If you're a primary care physician, you're used to having a diagnosis code, and then you get reimbursed for things, so it's supported financially. There are just too many patients to see in a day, and there's very little incentive for this. So about ignorance, the basic ignorance over the years, and some of this has been shared with cardiologists, although cardiologists have generally advanced quicker, are basic misconceptions of coronary disease. If you believe that real disease equals stenosis, you can't understand why we would be looking for atherosclerosis, that kind of thing. A lot of misconceptions about testing, that how is it that you had a positive scan, but the cardiologist did a stress test and it was normal, so that must be a false positive. And misconceptions about risk assessment generally. Who's really at risk in a practice type of thing. There's an uncertain standard of care, and the common phrase is, this doesn't change my management. There are conflicting messages every time, whether it's Dr. Redberg or Dr. DeTrano over the years, or Dr. Lauer or others. Certainly Bob Bono's comments in New England Journal of Medicine fairly recently. All these things feed into physicians who are not adopting this and saying, see, I was right. And certain words are picked up, certain phrases. The ACC committees, it says we don't support mass screening, which most of us don't support. That gets into the media, that coronary calcium or carotid IMT is not something that should be done, and rather than the more specific messages about intermediate risk. So there's always the comment, if it's so good, how come the cardiologists are not doing this? And yet if you explore that with a family physician and ask them, how many cardiologists do you know that are true preventive cardiologists? Then they start realizing that maybe that is a misconception. And then vague or non-existent treatment protocols for coronary calcium and carotid IMT. Now, this is the kind of things that we hear from an ignorance point of view. I am very aggressive anyway. All of my patients are on statins. So if you believe that you are aggressive and everybody's on statins, it turns out generally a minority of their patients are really complying with it. This therapeutic nihilism prevents some doctors from thinking about risk stratification. If I'm going to be treating anyway, and I'm blanketing my patients with statins, then why do I even have to know who's the risk? I do have some concerns that the polypill movement might give this fuel more fuel, this kind of argument that why do we need to do risk stratification if we're going to give everybody a pill? This idea that you're not really measuring a real disease. blockage in a positive stress test is real. It leads to the idea of false positives, and then discussion based on ignorance of the distinction between calcified and uncalcified plaque. So we do hear a lot of patients where you're only measuring the calcified plaque. They don't understand the relationship between a marker, calcified plaque, and the risk of cardiovascular disease. This idea that it opens up a Pandora's box of further testing that'll lead to angiograms and other things. And that's very much supported by comments by some of the cardiology experts, so to speak, that it's going to lead to more testing. When in fact it actually should lead to less testing and more testing on people who have a high pre-test likelihood. So it leads to much more appropriate testing in my thing. So the way cardiologists will say this to us over the years is, it doesn't tell me what I want to know. And then I always say, you're absolutely right. What you want to know is who has the highly reimbursable lesion called significant stenosis. It actually tells you what you don't want to know. Who doesn't need your services? So that's the way I address it with cardiologists, because it doesn't tell me what I want to know. You say it's absolutely correct. It tells you what you don't want to know. Who doesn't need an angiogram? Who doesn't need further testing? And then, of course, there's the comment by primary care, the cardiologist not doing this, why should I? Okay? So there is a diffusion of responsibility that occurs. Too many patients, too many distractions in keeping up with things, this orientation of being sort of a reactive. People come in with back pain, they come in with chest pain, doctors know how to react. When you come in with something that has no ICD-9 code, no diagnosis code, it's very hard. There's not a call to action if you've had a family history of premature heart disease. Doctors are not really thinking about, boy, let's do some risk assessment. They're going to react to chest pain more than that. And I list this as fear. Doctors don't order tests that they don't know what to do with. The worst thing, for whether it's advanced lipid testing or it's coronary calcium imaging, you don't order a test because you're afraid to get the results back and then it makes you look bad. So that's a problem. The test routine, this is a phenomenon that I think very few people talk about. These tests routinely embarrass certain physicians, leading to resentment. When a patient comes to a doctor after a self-referral and finds out that he has more plaque than 97% of men his age, he now says to the doctor, A, how come you didn't mention this test to me? Or at least that's implied, so it puts the doctor in defensive. And second is, you told me I was fine, my cholesterol was fine, and yet they're making all sorts of recommendations of further testing and things I might need to be. So the test, this is something that if we can't get doctors to embrace this, we're going to get a lot of problems, because the test does often contradict a physician's understanding of risk. This fear that leads to more work and tests on the part of the doctor. There's a loss of control, primarily because of resentment of self-referral. There is some fear of insurance company reprisals if you order the test too much, or it creates downstream revenue, even if that downstream type of cost, even if the downstream is warranted. And some doctors feel that since they don't understand what to do with the result, they just say all you're doing is creating victims, fearful people who now, they don't have a real disease, but now they're being told they're at high risk. And since they can't imagine that you can actually stabilize them or reverse heart disease, then that's a problem. And finally, there's no incentive. The perception of prevention is a waste of time, not covered by insurance. There's a lot of financial paternalism out there where doctors can't imagine ordering a test that's not covered by insurance. And so they say to the patient, they don't even mention the test, and if they do, they basically say the negative, well, it's not going to be covered. So that's a real problem. But almost all of them say, by the way, my brother-in-law is in town, could you scan my brother for free, or something like that. So there's a lot of that going on. This leads to non-reimbursable discussions with fearful patients about diet and cholesterol. If you do a test and a patient says, can you go over the results, you're not only doing a test you don't make any money doing, but now you've got to enter into a discussion that might take 45 minutes in reassuring the patients, and doctors resent that. So we need to show physicians how to make money and to separate one's practice from traditional modes. This inner dialogue goes on about screening modalities. I don't have time for this. I have too many patients. I wouldn't know what to do with the results. If it's so good, how come the cardiologist not doing this? And it's a money maker for others, but not me. Now, George came up with this thing, this Reverend Jesse Jackson kind of thing. We must educate, automate, and compensate as a solution. So education is important for physicians, empowering them to understand this so they're not fearful of the results, with clear evidence-based algorithms and tools, like pocket guides and that kind of thing, practical protocols. Automate this for the staff, identify patients who really need the test, direct staff to initiate screening protocols and follow clear treatment protocols, and then figure out ways to compensate doctors. I think the best way sometimes is to show doctors how it can change their practice. If you're a concierge physician charging a few $1,000s a year and trying to attract more people, if you can add these kind of tests and say that you have a sophisticated preventive cardiology program, and this year your goal is to prevent heart attacks in your patients, that could bring in more patients. So certification and recognition, those kind of things are important. Better mechanisms of reimbursement, and make physicians feel like partners. So I'm going to show you 2 quick ads of how I try to do that. And I think it could be applied to SHAPE very nicely. So here, there was a cardiology group called Aurora Denver Cardiology Associates, who in general showed some resentment towards the fact that so-called entrepreneur, me, would bring in a technology like this into Denver, and they didn't have this. So I approached them and I said, why don't we become partners? And so I created this ad that was advertised in theater magazines. If your heart scan looks like this, you may never need to see a cardiologist. Thousands of Coloradans with heart disease have been diagnosed and treated by superb physicians at Aurora Denver. Okay, and it goes into spend 10 minutes with us, and you may never need the services, but if you do, they're excellent physicians. So it sort of brought them into the fold, I think, and as a way of making the technology look good for other people. So I think that's a lesson that we can always do for SHAPE, is to try to do some fusion marketing and get involved with other organizations that make them look as if they own this, and they came up with the idea. And finally, here was an ad that I did for family physicians. Colorado Heart and Body Imaging is looking for a few good docs. And basically, your practice should meet with us if, and it mentions all the reasons why a practice might want to learn about this and improve their own practice. And so that's the, and this was not only for heart disease, for other things. I'm using quotes like this. So one doctor saying, the technologies at Colorado Heart and Body Imaging have revolutionized my approach to preventive medicine. Another doctor saying, primary care physicians need to take intellectual ownership of these technologies. I don't know if George has any comments on.
Go back to your Yeah, I just had a few more comments. I think that with regards to the primary care physician, if there is uncertainty and mixed messages and so on like that, that's just going to be a non-starter for them. I think that one of the, from the standpoint of education, we need to be clear and consistent in our message to them. And I think that's one of the great strengths of what Marge Lovell has put together with the PAD Coalition. It's a coalition of 84 organizations all singing from the same hymnal. It makes it clear what the message is and what needs to be done. But that's just the easy part. The hard part is a systems issue, and that is if you're seeing 35 to 40 patients a day, how can you take time to pause and do something that is preventative in nature and not reactive? And that's why this whole issue of automating the system, all of the thinking has been done, the protocols and algorithms have been worked out, and now it is going to happen unless the practitioner stops it. So empowering the staff to automatically do the right thing, I think, is the way to really get the job done. And then finally, to compensate for that. And one of the things that Harvey and I talked about is what about the ACC, the American College of Cardiology? I've been very active in that organization and serve on its board of trustees, and the ACC, just speaking about that organization, does not tend to endorse things. It tends to create guidelines and so on like that that maybe began as from other organizations, but as developing it in its own process. And I think that the way to get it to have the ACC more involved is for us to participate more in the ACC on its committees that are relevant to this, and to be one of the organizations that the ACC recognizes and acknowledges, just as Society of Atherosclerosis Imaging and Prevention is, and SCCT and so on like that. I would love to see SHAPE as one of the societies that is formally recognized by the ACC and so on like that. And then I think participation from within the ACC, I think, is really the way to bring this further.
Thank you, George. We're going back to the first few slides that Jim and George elegantly put together. These are really the key issues. We sit here for days and months and years, come up with greatest guidelines. If we can't get them to work by practicing physicians, we're not as smart. So what are those barriers? I'd like to make sure that we create a little bit of brainstorming and discussions on these slides. Can we go to the next slide that you have? So ignorance. And so the conflicting messages and things that people, practicing physicians hear. Let me start with you, Harvey. You have some of these discussions from our previous meetings that they hear from U.S. Preventive Task Force, they hear from AHA, but our primary care physicians are really an AHA advocate, or they're pro-Framingham, or do they even know Framingham? Most of them don't even know all of these guidelines. So are we facing a serious status quo concept in the primary care physicians' offices, that they defend Framingham, they're defending U.S. Preventive Task Force, or just because they don't know?
I think they're following the path of least resistance, and the average doctor just doesn't have the time to deal with prevention. There's no financial incentive. I think basically it boils down to time and money. And those are very difficult barriers to overcome unless the AHA or the ACC issues a guideline saying this is what you should do.
So time and money. They don't have cardiac calcium scan in their office, so that's another issue. If they had carotid INT, which I know some of these internal medicine doctors brought to their clinics, and they do that. They have incentive to do it. Steve, what do you see?
This is somewhat relevant, and I appreciate Dr. Rowe's comments. About 10 years ago, we began using ultrasound contrast agents, microvolts. And thank you. And they were FDA approved. Now there's several of them out there. And over the years, there's been a clear advantage to using these for cost effectiveness, reduction in downstream costs, lack of radiation, all the right things. So for 25 years, we've run a conference saying, why aren't these being used by clinicians worldwide? It's the right thing to do, but that doesn't always work. In fact, what has changed the world now, as of this June, ICAL, which is the Inter-Society Commission Accreditation of Echo Labs, put out a document which accredits every lab in this country, says you must use them for certain indications. And if you choose not to use contrast agents, you must have a policy stating why. I hate to admit it, the right thing doesn't always win, the negative stick is a lot more.
A lot easier. So that's what Harvey
You
said.
need a
least-
guideline.
least-
And
Yeah.
accreditation, so if you're gonna build shape guidelines and accreditation, then people will do it, but not out of.
Yeah, we're going to get to the accreditation when Jeff is going to talk about. But the point here was clearly boiled down to knowledge, cost, incentive, and availability of the test, and so on. Matt?
So I mean, we've been very successful in Los Angeles at educating our physicians. We have symposia sponsored by Pfizer, AstraZeneca, whoever. We put on dinner programs, we bring them in, we give them a certificate for a free scan if they want one. They can use it on themselves or they all want a free scan anyway, as Jim alluded to, but we make them work for it, so it's not we tell them it's a start issue. We can't give them a free scan just because they were referring doctor. That would be a referral perk. So we make them come in for a little symposium if they want to get a free scan certificate that they could use at their leisure or for whoever they want. And we just give them a little talk on this topic. And pharmaceutical companies love it because they're not allowed to do things like give out free scans, but I can. So it empowers them. They pay for everything. They bring in the doctors. The message obviously can be a little bit about the benefits once you find plaque or of imaging. It would work equally well, I'm sure, for IMT as calcium scoring. Once you educate the physicians, you lose a lot of this resistance. At least, you educate, right? As George said, and I think that's going to be important. And obviously, not everyone's going to want to come in, and not everyone's going to be interested. But if you get some of the referring doctors to understand the test, and now that we're starting to get reimbursement from certain payors, some of the burden is over. Right now, it just makes the Blues look bad that they're not paying for it if everybody else is paying for it. And it doesn't seem like it's a bad test. It's just that the Blues are a bad insurance company. And that's an easy sell if they're the only ones who don't pay anymore. So you can turn it around, I think, and we're starting to get there. It's still a battle, and there are going to be groups that say it's a bad test. But I think those naysayers are going away.
Yeah, well, but the doctors, the practicing doctors are not Steve Neeson or
Right, but they're still going to have. I mean, some have issues though.
They don't have any incentive to say no or be academic about it. But one thing is awareness. So you're creating local workshops, and maybe weekend workshops, and give them their certificate. And then how do you address the financial incentive? They won't gain anything by sending to you.
Right.
They have tried IMT in their lab, they make money, and that's definitely a problem.
Right, so there's downstream testing that they could benefit from, right? They're also perceived as better doctors if they're using high-tech technologies. The concierge doctors love that if you can convince them that this is part of their mission. And for preventive doctors or the chelation doctors or all of the kind of fringe doctors, this is like a bread and butter test for them. They have to do this test. Not everything. I think a lot of doctors want to do the best test for their patient. I agree with you that there has to be some. We can't tie a financial reward to it in every case. And even a lot of people who use carotid IMT send it to a core lab, a cardiology group that has the IMT data. So I think it empowers the primary doctor also to keep the patient because they can do a cardiac test now without losing it to the cardiologist. So
now, yeah, go ahead, Tasneem.
More, I'm talking from an academic center perspective, not private practice.
Monique, could you turn the microphone around, please?
So at my center at University of Southern California, the problem is not to convince the doctors about the utility and the importance of screening and CAC and IMT. They are desperate to refer patients. The problem is lack of reimbursement. So we started the service of IMT and we delivered it for about a year, and we could not accommodate it as our lab grew in other areas, and we had to actually stop the service. And we are currently in the process of figuring out a financial or business plan for this. As we started a women's clinic, and we desperately want to start doing IMT, and I think it might even come down to either us absorbing the cost of it or asking the patient to pay some of this, and that is the part where the hospital does not want to go. They do not want to ask the patient to pay for screening. And so we are a very conscious group of physicians who totally understand the importance of the test, but we are not doing them because of lack of reimbursement.
Physicians, do you think physicians would ask patients to pay out of pocket, practicing physicians? Jim?
Well, first of all, I want to mention that I want to confirm what Matt mentioned. I was very impressed visiting Matt's place for a talk where he really, I think, has turned the tide in the community with enough critical mass of physicians who understand this and appreciate what UCLA Harper is doing, that any physician that's not involved would feel like an outlier, I think, in that community. So I think it's a tremendous educational service that I don't think has been duplicated as well anywhere in the country. And then, what was the question?
Practicing physicians, would they actually directly, let's say the doctor has
either
poured out the IMT or has in his own facility, would doctors take the initiative to actively market their patients and have them pay out of pocket? Or traditionally we're bound to our ego and we don't want to charge accept?
Well, I think physicians, I try to change the dialogue and give the physician an idea of how to approach it to the patient, which is the physician should be neutral about the financial thing. In other words, they're not, I remind physicians, you're not their financial planners, okay? And so the way to say this is there's a test out there. If you decide to have it, here's how I'm going to use it. You know, you may have to pay out of pocket. I think it's about $100, $200, whatever the cost is. But if a physician shows that he preserves his or her traditional role is to be a guide, what's the best test out there and the best capabilities, and doesn't make a judgment, doesn't say, I think you should have it, or whatever, but say, here's why, or say, I think you should have it, but here's why. And most patients, unless they're really in financial problems, will figure out a way to get a $100 or $200 test if the doctor can demonstrate how useful it's going to be.
Right, we're going to get back to you.